We now have about half an hour for a panel discussion. You've heard from these very distinguished colleagues who very kindly joined us here. Do continue to send in your questions. And as they come in, I will, of course, put them to the panel. But I just wanted to start off with some of the themes that we enjoyed hearing about in the last hour or so. Clearly, there is great optimism. Clearly, there are very great opportunities. The foundations are very strong in our country. But we've heard about workforce, we've heard, and we'll come in particular in the next session to the question of the adoption of innovation. We've heard about the importance to secure patient longer-term capital into the great innovative companies that we have established in this country. We've heard a lot about the complexity of dealing with the single main client for innovation in health service in our country, which is the NHS. How, in looking at all of that, both the positive and, as I think we've rightly said, opportunities to be exploited in the future, how do we identify the way that we can collectively address those issues? Because much of what we have heard so far this morning are issues that we could have heard 2 years ago at our conference, 2 years before that, and 2 years before that. Now, that's not to say that there hasn't been substantial progress in that period of time. But we're at a moment in time now, if I've understood correctly what our 5 distinguished colleagues have said to us, which is slightly more critical, where there is the opportunity to push this all forward, have a profound impact on the delivery of healthcare in our country through achieving that profound impact, ensuring that, for want of a better description, our democracy remains secure, because a failure to deliver healthcare effectively and in a way that is appreciated by the majority of our fellow citizens will start, in their minds, to question whether actually government is working for them. If this fundamental right, this expectation to be delivered, to be the beneficiary of high-quality, safe healthcare is not provided, then they might turn to other forms of political engagement, slightly more populist, rather than engaging with mainstream democratic political parties. We've also heard about the challenge of workforce. And if it's not a system that is appealing to work in, much of the talent might go and work in other appealing systems, and all the innovation we have will have nobody here to apply it. How do we get to a collective place to address these challenges? I'll start with Ian.
Yeah, thanks very much, and a good jump-off point. I am optimistic, despite the problem that I set out. I'm optimistic because I think this is an important political moment, and it's also an important investment opportunity moment. If I were to dissect that wait list into what's actually really going on, fortunately, of those 7.5 million people on the national wait list, only about 10% actually require an inpatient procedure, need an operation. The bulk, 6.5 million plus, is a diagnostics question. It's not a therapeutic question. There is care clearly required for some of those people at the end of diagnostic pathways, but it's not operative surgery. So our big problem is, if I were to throw out some challenges for the audience, AJ, it's how do we get to understand what is in the waiting list? It's largely unsorted, despite having some information, but not all of the information that Patrick referenced earlier. How could we interrogate more intelligently that wait list? And then how can we prioritize? How can we use different operating models to make a difference to many on those wait list? How do we change passive waiting to active waiting? How do we give those citizens who are waiting the ability to influence their own care while they wait? It seems odd to me that it's a passive process at the moment. And then how do we give access to diagnostics, particularly through different models? And one of the problems, I think, in the UK NHS at the moment is, and this is heretical perhaps for some of my colleagues, actually the revenue settlement is not that bad. The amount of money we put into care for patients annually in terms of revenue is not that bad. It's 9.5% of GDP, which is similar to many other Western European countries. What is absolutely critical, and I am optimistic, particularly again from yesterday's budget, is that we are one of the least capitalized health systems in the world. We're right at the bottom of the OECD capital index for investment in healthcare. And I would argue that much of that should probably be in diagnostics and technology rather than perhaps in hospital buildings. But on that heretical note, I'll pass on.
Patrick.
Well, I do think it is alarming when you look at Aradaz's report that the productivity has been falling in the NHS, and we've been spending more money on it, employing more people, and satisfaction and quality has gone down. And I think that's very disturbing, and things were moving in the wrong direction before the pandemic. I mean, clearly the pandemic has been bad. So I think the most important thing we need is some agreed measurements that really reflect quality and outcomes in health and care. And I think one of our central problems is that at the moment, the one that we all recognize is the number of people waiting for procedures. And that is a very unsatisfactory measure. It doesn't really tell you anything about productivity or quality, other than that there's a problem. So I don't think this is easy to do in a system that is free at the point of delivery. I do think it's a very good thing that we are moving to a more integrated care system approach. But I think unless we come up with some measures that we have faith in as really reflecting both what we're putting in terms of investment and what we're getting out in terms of quality and outcomes, I don't think we're going to be able to improve things. So it's partly, being a scientist through and through, I really believe you have to measure things to drive improvement. So I'd like us to come up with some measures that we think really matter, both in terms of quality and efficiency.
Yeah.
Please.
I've always been in the healthcare industry all my career, lived many years in the US, many years in France. I think for me, it's probably not about the money today. Money will help, but it's really about organizational structure and process. Some examples, diagnostics I think is critical. In the US, I've had a CT scan at 3:15 in the morning, right? 24-hour usage of CT scans, all the diagnostic tools, operating theatres 24/7. I put in place some hip factories, some knee factories. I think the whole, the GP, the front-end GP, God forbid I'm being heretical here as well. I don't think there's fantastic productivity there. I wouldn't have MDs scurrying away to join venture capitalists like us. They'd be obliged to continue practicing for a certain number of years after they have completed. So I think there's some real fundamental organization issues. We need to run hospitals like factories, and we need to bring skill sets in the competence of the managerial level in particular to really run them more efficiently. I think just very quickly on the scientific, the innovation side, I think we as the UK have got to be incredibly parochial. UK Biobank's a great example, incredible data. The majority of the intellectual IP that's being filed is being filed from groups outside the UK. There have been 2 companies that have gone public based on UK Biobank data, both Finnish. And so I think we've got to be a little bit parochial. I think we've really got to join the dots, data pools, genome centres, hospitals, universities, and really try and figure out unfair advantage such that we capture as much of our capabilities we have.
I guess agree with all of the above. Just thinking slightly around those international links, I think we can be quite guilty in the UK of being quite insular and thinking we have all the answers. We've engaged a lot internationally and actually shared a lot of intellectual property about how to do things well. But actually that's beginning to shift now. And I think there is a lot of learning from perhaps the US system and how you support, commercialise, grow and stabilise companies within their ecosystem. And equally in the Middle East, they have a blank sheet of paper in a lot of these Gulf states. They're designing health systems of the future. And actually there's a way about looking at how they can innovate in healthcare delivery in a way that we don't have capacity or time to do. So it was just to share a little bit of that. I think it's really important to look outside of our own economy.
Please.
Yes, I think when we look at it as a sector, I agree with everything said. And I think it comes down to productivity. And if you look at where people and where young people want to go in their jobs today, and you compare cross-sector, the 2 sectors that are actually lagging or causing the most increase in costs are education and healthcare. And I think, Ian touched upon it, I'm not sure how many decades ago, but how care has not changed since when you started. It really hasn't. Same thing with education. It still takes 30 people to 1 professor that hasn't gotten more efficient. When every other sector is getting more productive and more efficient, and wages are going up here, you have to compete with that, and that brings up your cost base. And that's why people ask, us as investors all the time, why is education and healthcare getting so much more expensive? It's because everything else is being more productive and you're not. And I think that has to be the answer.
So there are a number of interesting themes developing here. One is around what you would do if you were a single intervention, if you were appointed CEO of the NHS tomorrow to drive the transformation. So you can't do many, many things. Why don't we start with Tim in the middle?
Oh, goodness, thank you for that. Yeah, I asked David Pryor, who's the former chairman of the NHS, that question just after he retired, and he kind of scratched his head and pulled his hair. Now, he doesn't have much hair left, but I would change the organisation. I would centralise it again, I'm afraid, and I would employ some really high-quality individuals. I'd centralise purchasing. It's now done at the trust level. It makes no blooming sense. There's not much difference between total hips these days. You can save billions of dollars. But I think you've really got to start to look at and learn indeed from other constituencies about how you can run a holistic approach. We've got this national health services is national. We've got to put in place, and it will take some investment. But I would certainly have a much more leaner management, much higher quality, better paid individuals, and look to put in place processes across the board. And I may even, Elon Musk, maybe we can get him to do something really useful as an example. But really changing the way these things work.
Let's move on from being CEO of the NHS to the question of is it possible for us to understand what the impact has been on productivity and the necessary requirement to broaden or to increase financing for the NHS through its lack of routine ability to adopt technology quickly? Has anyone looked at that? Do we really understand what this gap is now as a way of helping us understand how we might move, as we will in the next session, to looking at the adoption of innovation? Ian?
My first response to that, Asia, is that very often we've put in people to try and mend broken processes. and we need to fundamentally rethink that model. If I was allowed to answer the previous question,
Yeah, you can.
what I would do...
you have an advantage being a CEO.
I would industrialize diagnostics. And when I mean industrialize, I mean truly industrialize. And completely change the model. There is no reason why we should not be CT scanning at 3:30 in the morning. Often there's someone from the emergency department in the CT scan. We should really separate out this, separate out the models. But it's not just the acquisition of images, but also doing something about them at the point of acquisition. So industrialized diagnostics, but also decision-making downstream from that diagnostic. I believe, and actually it's a good context really to be given, the challenge by the current government of restoring constitutional standards within the term of this Parliament. That is that the constitutional standard is you should not be waiting longer than 18 weeks. So that first slide, the slide on the left, we've got to make major differences within 3 years, really, within to have it within shape by the next election. The only way I think you can do that is industrialise.
In terms of the innovation landscape, and we've heard a lot about brilliant companies and brilliant technologies and so on, things like along the way that have been thought to be the future, examples given here, telehealth, blockchain, are mostly gone. What do you think's next to go, to fail in our innovation landscape? Very brutal question, but who would like to take that?
Maybe I'll have a go. I think AI will take a lot longer to actually translate. I think if that was the essence of what you're, I think it will. I think it can play a fantastic role. Obviously, Babylon Health isn't a very unfortunate example of probably getting there too early to kind of replace GPs. But there's definitely the essence of that. I think will be really important particularly as we talk about prevention. Shortage of GPs as well. So I think AI will have a significant role, particularly in the diagnostic space at some point in time. But we shouldn't have too high an expectations in the short term.
Michael, there's a question here about whether Blackstone might be able to intervene to deal with the NHS infrastructure, your major... how about signing Mr. Schwartzman up to that?
We've looked at hospitals. Infrastructure is clearly a big theme and one thing we've been looking at investing in. I'm not sure how much you'd have to get people politically secure with actually selling off things. I'm not sure how well that would be accepted on hospitals. It certainly happened in the US. You have a lot of private hospitals. Obviously, we have private hospitals here. It would certainly provide more capital. I do think it could. You could easily get a lot of infra funds interested in doing something like that. And that funding could then be used by the NHS elsewhere. There's certainly, if you look at everything, if we can privatize prisons, if we can privatize schools to a great extent, why not part of this? You could definitely bring in some infrastructure capital.
And how complex, across the panel, do you think that is from the political point of view? Because, that's the question. Clearly, part of the budget yesterday was to signal the government's view that it would increase borrowing for capital projects rather than recurrent revenue, which seems a sensible thing. But government can only borrow so much. Yep. Private sector can invest as much as it feels confident to do. But there is a political question. Ian, how do you think that might be addressed in terms of the NHS? And private sector investment?
Well, my personal view, this is a personal view, is that it's going to have to be a mixed investment economy. And although certainly in Treasury orthodoxy, private finance investment was, in inverted commas, certainly in the last period of government, has been a bad thing. But I cannot imagine a future that doesn't see a more creative partnership between public and private capital investment. And I strongly believe a point that you made earlier, AJ, which is that the healthcare system in this country is a wealth creator. It needs to be a wealth creator, not a wealth consumer. And that we have that opportunity, coupled with the brilliant life sciences opportunities that Patrick and Tim and Susie mentioned. But I think we have to get on with it. And we have to take some risks. And I strongly believe that the new Chancellor has perhaps a more creative view of the future.
In terms of that private sector, really driving the infrastructure investment opportunities in the NHS, real estate opportunities, real estate rationalisation, many of the issues recently identified as being critical to future productivity in the NHS, that we have to invest in the estate. You're optimistic that there may be a more welcoming approach by government now. Are there other constituencies associated with the National Health Service in terms of the workforce, other stakeholders, patient, other groups that interact, that would need to be brought along on that journey as well? Patrick?
Well, there's a major issue of trust. And I mean, I think one of the challenges is the idea that the NHS is a sort of state organisation rather than a blended organisation. And I think we're going to have to see that change. I think the NHS is going to have to be much more open to external capital, much more open to industrialisation of its processes, and much more open to sort of serious scrutiny of productivity. But I do think that's going to require a sort of change in our national religion of viewing the NHS as something that is completely state-owned and determined.
Tim, actually both of you, beyond investment in infrastructure, there's always been the question of how we should invest in the data that will become available from managing patients' healthcare and so on. Those data rightly have been identified as having the primary objective and principle of improving the individual's healthcare outcomes and indeed ensuring that we can utilise resource in the most effective way across populations, communities, patients, and so on. But the data provide other opportunities as well in terms of driving the research and development agenda, potentially as a result of that engagement with commercial interests.
Yeah.
How should that be handled? Because that has been a major problem and in many ways has stifled the opportunity for data to be properly applied across the NHS because of the lack of investment.
Yeah, I think it's an incredible opportunity that has not yet been grasped. We have this amazing laboratory of a national health service, and if we can track all the patients' data curated in an efficient fashion, then we again have another, never mind the UK Biobank, Genomics England, we've got this incredible laboratory of data that you can interrogate, access, and commercialize, right? We should be able to if a US company is looking at a particular orphan disease of which there's only 20,000 globally, we should be able to dial up those patients, offer it to this company as part of a clinical study, and maybe we get free drugs for the rest of their lives. So I think it's an incredible resource, and particularly as we're thinking about improving diagnostics, how do these patients respond to treatments. But it will take, there's an organisational piece and a political piece. Just in closure, there was discussions about selling off the NHS data to Google 4 or 5 years ago, and everybody was in a Ferrari. So I think there's also this political aspect to it as well. It's got to be resolved. But
we have to do things very, very carefully. Susie, in this question of data as a resource, what do your members say to you?
Clearly it's a vested interest in how data outcomes are measured and used, and actually that was one of the areas I was going to suggest in terms of bringing in the wider stakeholder group around delivery of healthcare. And I'm slightly biased because I think it's such an incredible area of focus and potential for the NHS, but I think value-based healthcare is critical to looking to the future. It brings in private sector, it brings in funding, it brings in industry, technology, innovation, data, and it's about a patient's position in their wider sort of local economy and how they contribute to society. So it sounds ever so slightly theoretical, but I just think it's a really important way to consider redesigning healthcare and how you bring people on that journey with you and bring in the private sector.
And in terms of that, with your sort of unique positioning across the industry and then your previous experience, I know at UCL Partners and things like that, where do you think the greatest challenge is going to be in terms of solving that? People, we're all very enthusiastic about it. Everyone sees the great opportunity. But if we're going to get to a place where we can solve that question, bearing in mind the constituencies, academic, clinical, patient, commercial, government, and so on, what's the key point?
Well, I think certainly from some work I did at UCL Partners, that the challenge is who owns the problem. And I think when integrated care systems were put in place, I think that was recognised potentially as leadership around population health and what that means around value-based outcomes. It's not entirely as clear as that. And I'm not sure what the answer is, other than I think sort of long-term strategic partnerships with industry that aren't about transactional buying and selling, but holistically viewing care pathways and how they can be improved, and looking at outcomes will be supporting kind of trying to identify how you solve that problem.
Now we're going to come throughout the day to this thorny question of workforce. And one of the interesting workforce questions is how do you first develop people? How do you motivate them to stay committed? And I think we've heard some comments about that. But how do you drive the opportunity for the NHS workforce to see themselves as innovators? And indeed, how do you provide the opportunities for them and those working in healthcare more broadly to move seamlessly between their health, their science, and potentially their entrepreneurial elements of their careers? Have you, Susie, in your experience, and are there pathways by which people can come in and out easily from the commercial and back into the public and science sectors?
I mean, there are fabulous national programmes, of course, supporting true innovation that's born within the NHS and within the system that are all about kind of the actual need. Of course, you'll probably all be familiar with the Clinical Entrepreneur Programme and the NHS Innovation Accelerator. These things are wonderful and they are set up to support national adoption, as are the health innovation networks. They're beautiful on paper, they work wonderfully in parts, but it's not a perfect system. That's what I'll say.
And Patrick, how are you doing this in Cambridge? How do you get brilliant clinical academics to go to spend time working in industry, in the innovation technology industries and so on? And how do you provide the opportunity for them to still be clinically engaged?
Well, perhaps I shouldn't say this too loudly, but there's an extraordinary thing if you're an academic in Cambridge. There is an unlimited right to go and do other things. We have no... private practice is controlled if you're a clinical academic, but in terms of consulting for external companies, there is no limit as long as you are still delivering for the university. So I think that flexibility is really valuable. And I don't think within the NHS people understand how they could get partial release from their job and do something else. And we have deliberately been as flexible as possible because I don't want to lose people from the university. Obviously get a bit upset when someone gets recruited by AstraZeneca, but what I want to say to them is, look, why don't you keep your academic title in the university. We'd love you to come and do a clinic in the hospital. And that really fosters, bilateral understanding, and I think has worked well. So flexibility is the main thing. And I think personal attention to people as well, AJ.
Well, we'll come to many of those themes as we move on. Thank you all very much for your contributions to this marvellous panel.
The Harley Street Health District, the home of healthcare since 1860.